At RSNA 2023, experience the future of medical imaging when the radiology community comes together as we help you discover how to lead through change. Immerse yourself in the latest technological developments. See imaging innovations in action. Sharpen your skills with high-impact learning and connect with radiology colleagues from around the world. Join us November 26th through the 30th for the biggest week in radiology, in person, virtually, or both. Register now for RSNA 2023 at rsna.org/register. Welcome to RSNA Radiographics podcast. My name is Lily Wang, a neuroradiologist from the University of Cincinnati. Today we have a special guest, Dr. Asha Sama, a pediatric neuroradiologist from Vanderbilt University Medical Center.
Hi, I'm Dr. Asha Sarma. Thank you for inviting me to the podcast.
Today's podcast is on the article called Systematic Approach to Pediatric Macrocephaly. This is by Dr. Sama and colleagues from Vanderbilt and Emory Universities, led by Dr. Jennifer Huang, who is currently an abdominal imaging fellow at Brigham and Women's Hospital. So what is the definition of macrocephaly?
Macrocephaly is a general clinical term defined as a head circumference greater than 2 standard deviations above the mean, or 0.5 centimeters higher than the 97th percentile circumference.
What imaging modalities are useful for evaluation of macrocephaly?
We can use ultrasound, MRI, and CT, and they play complementary roles, as we'll describe. Ultrasound is often the best first modality in young infants with an open fontanelle, especially when there are no other concerning symptoms, and those with known abnormalities who require frequent serial follow-up. Ultrasound is advantageous because it's readily available, portable, and performed without sedation or ionizing radiation exposure. However, it can be less helpful in patients who have a smaller fontanelle, like older infants, and it is less sensitive and specific than MRI for a lot of different disease processes that we might see.
So when we use an MRI, should we use the rapid MRI or a full MRI protocol for evaluation of macrocephaly?
Rapid brain MRI protocols, which generally include single-shot T2-weighted MRI, allow screening or follow-up imaging without the need for sedation in many cases. However, you can miss some parenchymal abnormalities, so that's on a case-by-case basis, and I wouldn't usually use those for anything besides extraaxial collections or processes involving the ventricles like hydrocephalus. Multiplane or multi-sequence MRI may be needed for definitive evaluation for multiple disease processes and may require sedation.
Do you usually give contrast for MRI?
Contrast material is rarely needed unless infection or tumor is suspected.
So when would you use CT?
CT is sometimes used in lieu of MRI, including in the acute setting and in patients for whom MRI is not feasible or is contraindicated for some reason. And some of the strengths of CT are the rapid acquisition speed and widespread availability. In addition, CT can sometimes be advantageous for assessment of skull abnormalities.
Yeah, so why is macrocephaly more common in patients with open sutures?
A lot of different disease processes lead to macrocephaly only when the sutures are open. Otherwise, in a calvarial vault with closed sutures, space-occupying disease processes lead to increased intracranial pressure. According to the Monroe-Kelly hypothesis, there has to be equilibrium among intracranial constituents due to the fixed cranial volume.
Can you give an example that explains the Monroe-Kelly hypothesis a little bit more?
Yeah, in the fixed space of the skull, if the volume in one compartment increases, the volume in another has to decrease, which is why a large subdural or epidural hemorrhage causes mass effectant herniation in a patient with closed sutures, but may instead cause macrocephaly in a young infant with open sutures where the calvarial vault can still expand.
How do we classify causes of macrocephaly?
The method we used in the article first identify the compartment of involvement and then establish a differential diagnosis based on which compartment we're talking about. So first, we identify which of the 4 intracranial compartments has increased volume: CSF, blood or vasculature, brain parenchyma, or the calvarium.
What is an example of increased CSF leading to macrocephaly?
Benign enlargement of the subarachnoid spaces, or BES, is the most common cause of pediatric macrocephaly with an estimated incidence of 0.5 per 1,000 live births. It is most commonly attributed to delayed maturation of the arachnoid villi, with resulting decreased CSF absorption relative to production. The typical history is an infant presenting with increased head circumference above the 95th percentile that is crossing the percentile lines on the head growth curve. And the patient's age is also an important consideration because most cases of BESS are seen in older infants. And BESS often first comes to attention at routine well-child checks when the child is about 8 months old, and presentation before 4 to 5 months of age is unusual. And it's also important to know that BESS is often familial. So good family history is helpful to make the diagnosis.
Are they typically developmentally normal?
Yeah, it's funny that you should ask that because a very crucial feature of the clinical history of patients with BESS is that the child's development is normal or nearly normal without any neurologic signs or symptoms. And if there's any substantial developmental or neurologic abnormality, the finding cannot be labeled as benign.
What do you see on imaging in BESS?
On imaging, BESS is characterized by enlarged frontotemporal subarachnoid spaces without any mass effect. And there may be mild lateral ventriculomegaly, but the temporal horns usually remain non-dilated, and there aren't other signs concerning for hydrocephalus. The cortical veins may be seen traversing the enlarged subarachnoid spaces, and they can be best visualized with Doppler ultrasound or as flow voids on the T2-weighted MR, especially the coronal images.
So are there any worrisome diagnoses that can simulate BESS?
Yeah, it's important to remember that a key consideration in the differential diagnosis is clinically is subdural fluid collections, particularly in cases of suspected abuse of head trauma. However, patients with enlarged subarachnoid spaces for any reason, including BESS, may be at increased risk for subdural hematomas. Subdural fluid collections and enlarged subarachnoid spaces can also coexist, and distinguishing between the two entities on imaging can be challenging, especially on CT. However, if the cortical veins are displaced away from the inner table, the diagnosis of a subdural fluid collection has to be considered. And with subdural fluid collections, the inwardly displaced arachnoid membrane may be visualized between the inner table and the brain surface at ultrasound and MRI. Regardless of whether the subarachnoid spaces are enlarged, correlation with clinical concern for child abuse is essential when a new subdural fluid collection is identified. And when this finding is made, it warrants communication between the radiologist and referring physician who may pursue further workup.
So what is the treatment for BESS?
BESS is self-limited, typically with spontaneous resolution of the enlarged subarachnoid spaces by the age of 2, although the macrocephaly may persist beyond that point.
Okay, let's shift gears a bit and talk about hydrocephalus. It is another important cause of pediatric macrocephaly. So how do CSF dynamics change in patients with hydrocephalus and what causes it?
Good question. I think that this is a complex question. Hydrocephalus generally is due to a mismatch between CSF production and absorption. And normal CSF dynamics relate to a slew of factors, including production of CSF, hemodynamic changes across the cardiac cycle, compliance of the brain parenchyma, circulation of the CSF, absorption of the CSF, and hydrostatic exchange of fluid from the CSF compartment into the venous circulation. Most of the causes of pediatric hydrocephalus relate to impaired absorption at the level of the arachnoid granulations or inadequate CSF circulation due to an obstructing lesion such as an aqueductal web or a tumor. Choroid plexus tumors and villus hypertrophy are relatively rare entities that can cause hydrocephalus due to excessive CSF production. It's also worth mentioning that hemorrhage is the most common cause of acquired pediatric hydrocephalus, most often affecting preterm infants who've had a germinal matrix hemorrhage.
You mentioned aqueductal stenosis, which can cause congenital hydrocephalus. How common is it?
Aqueductal stenosis is a common cause of congenital hydrocephalus, relatively speaking, accounting for 20% of the cases. And the cause of the stenosis may be intrinsic, like an aqueductal web, or extrinsic, such as a congenital cyst, brainstem malformation, or a mass lesion. And there are also familial forms. Imaging demonstrates supratentorial hydrocephalus and heavily T2-weighted sagittal 3D MRI sequences, such as BFFE that we use at Vanderbilt, are useful in identifying the exact site of aqueductal narrowing.
That's helpful to know. So what is the best way to perform follow-up imaging in pediatric patients with hydrocephalus?
Ultrasound is important in the serial follow-up of patients with open fontanelles, while low-dose CT or rapid brain MRI protocols are commonly used in older children. MRI allows more detailed visualization, including heavily T2-weighted sagittal MRI sequences we were just talking about that portray key landmarks such as the floor of the third ventricle and basilar cistern adhesions that are important for surgical planning when an endoscopic third ventriculostomy is being considered.
One of the rare causes of pediatric macrocephaly is hydranencephaly. Can we touch upon that?
hydranencephaly can be confusing the first time a person encounters it. The term refers to water brain and is thought to result from in utero anterior circulation arterial occlusion, most usually due to infection or trauma. And this can lead to encephaloclastic injury of the cerebral hemispheres, and the space gets filled in by CSF, which results in an appearance of a fluid-filled cranial with very little brain parenchyma left over. And the imaging features that distinguish this diagnosis from other superficially similar entities like hydrocephalus and alobar holoprosencephaly include absence of the cerebral mantle and the affected vascular distribution, where you might get a thin cerebral mantle, for example, in hydrocephalus, and a preserved falx and lack of fusion of midline structures, which helps differentiate from holoprosencephaly. The posterior circulation structures, including the thalami, posterior fossa structures, and posterior-inferior temporal poles, are typically spared in hydranencephaly.
Thank you. So let's talk about arachnoid cysts. They are pretty common. What are they, and can they cause macrocephaly?
Yeah, arachnoid cysts are circumscribed CSF containing collections that are most often sporadic and asymptomatic, but they can be associated with genetic disorders. For example, glutaric acidemia type 1. In arachnoid cysts, causing CSF flow obstruction can produce hydrocephalus, which can lead to macrocephaly. However, some of the arachnoid cysts may present with macrocephaly without hydrocephalus just due to the size of the arachnoid cyst itself. They can also be complicated by subdural collections when the patients experience minor trauma.
Where are these arachnoid cysts typically located, and what do they look like on MRI?
Arachnoid cysts can be found anywhere in the central nervous system, but are most commonly encountered in the middle cranial fossa. And suprasellar arachnoid cysts are more often symptomatic than our arachnoid cysts in other locations due to compression of adjacent structures in a relatively confined space. And for uncomplicated arachnoid cysts, MRI demonstrates a CSF isointense cyst with complete suppression of flare and without associated solid contents or internal enhancement. And it's important to remember that arachnoid cysts show facilitated diffusion, which distinguishes them from epidermoid cysts, which have reduced diffusivity.
Let's talk about a different type of cyst. Genesis of corpus callosum associated with interhemispheric cyst.
Yeah, these do differ from arachnoid cysts. So agenesis of the corpus callosum is sometimes associated with cyst formation in the interhemispheric fissure as a distinct entity from a midline arachnoid cyst. And associated hydrocephalus is common. And in agenesis of the corpus callosum with interhemispheric cysts, the cysts typically appear CSF isointense on all the pulse sequences. And MRI is recommended to fully characterize the associated abnormalities because agenesis of the corpus callosum is associated with more than 80 different syndromes. And some of the CSF anomalies that are most commonly associated include Dandy-Walker malformations, interhemispheric lipomas, and malformations of cortical development.
Yeah, I always tell the trainees to keep looking when you see a genesis of the corpus callosum and don't stop
So
there.
true.
Yeah.
So true.
So what happens when the blood vascular component enlarges?
Subdural fluid collections are a common finding in children who've experienced accidental or non-accidental trauma, and most of the patients with subdural fluid collections do not present with macrocephaly. However, as we're talking about young children with open sutures and large bilateral subdural fluid collections, a sudden increase in head size can be seen. You can recognize subdural collections as crescentic collections that cross suture lines that are limited by dural attachments. And cortical veins are displaced away from the inner table, which is a key differentiating feature from BESS, as we discussed earlier.
So this question comes out a lot. So should we date subdural collections on imaging, especially in the medical legal setting?
Well, that's a good question. And this is a hot button issue for me. I'm always dissuading people from doing that. So depending on numerous factors, subdural fluid collections can have variable imaging appearances and cannot reliably be dated using their MR signal intensity characteristics. And erroneous dating can have medical legal implications, for example, by placing the patient on a timeline with the wrong caregiver, and therefore a descriptive reporting approach is most appropriate. So, for example, the neutral term mixed attenuation or signal intensity would be better than acute on chronic, which should be avoided in this situation. And importantly, skull fractures are often absent in cases of non-accidental trauma because these fluid collections are thought to be caused by impulse loading, such as from shaking, rather than direct impact. However, it's always important to remember that no finding is 100% specific for non-accidental trauma. And therefore, this finding necessitates careful evaluation of the clinical history and the additional imaging findings in order to guide the diagnosis.
Yeah, I think this is really important, especially for the trainees that learn about the aging blood products. And then they're like, can we apply this to subdural? I'm always like, no, be careful, don't. So thanks for
Yeah.
clarification.
Outside
Yeah.
the protocol, all bets are off.
It doesn't work. Yeah. So what about intravascular compartment? The article describes Van of Galen aneurysmal malformation as a potential cause of pediatric macrocephaly. Can you tell us a little bit more about that?
Yeah, the term vein of Galen aneurysmal malformation actually refers to failure or formation of the vein of Galen due to a high flow arteriovenous fistula that forms in utero between the deep choroidal arteries and an enlarged median prosencephalic vein, which is a fetal structure that persists abnormally in vein of Galen malformations. And the two main types include the more common choroidal type, which tends to present earlier with high output cardiac failure, and the mural type, which typically manifests later on with hydrocephalus. And a vein of Galen aneurysmal malformation is thought to cause abnormal hemodynamics, which can lead to hydrocephalus and macrocephaly through two different mechanisms, both decreased CSF resorption. Remember, I said that venous pressure is related to CSF absorption, and if the hydrostatic pressure gradient is too much on the venous side, then the CSF resorption can be impaired, as well as aqueductal obstruction. And the diagnosis of vein of Galen, we'll just call it vein of Galen malformation for short, is often first made on fetal imaging or neonatal head ultrasound, which show a large venous structure in the pineal region, which represents the enlarged persistent embryonic median prosencephalic vein. So the vein of Galen actually never forms. And multiple small arteries typically feed this varix. Third trimester prenatal ultrasound may demonstrate increased resistance in the MCA and resultant cerebral ischemia, which is a phenomenon known as vascular steal. And this can be very, very severe with severe diffuse encephalomalacia, which is sometimes referred to as brain melt. The prognosis depends mostly on two different factors: how severe the heart failure is, which is likely a result of the shunt volume, and also the extent of cerebral ischemic injury.
Yeah, I remember studying for the boards, at least in Australia, that if they give you a head ultrasound and a chest X-ray with cardiomegaly in a neonate, they're probably going to show you vein of Galen malformation, so they get cardiac
Oh,
failure.
that's a great tip. And always remember, if you see a midline cyst on a neonatal ultrasound, to put Doppler on to make sure that
Yeah,
it's not a
exactly.
vascular
Make sure it's not a cyst
malformation.
or not a vascular to distinguish the two. Oh, so in
Right.
addition, tumors can also cause macrocephaly. Can you describe how that happens?
Yeah, the most common neoplastic cause of pediatric macrocephaly is choroid plexus tumors, although other large tumors can also cause macrocephaly if they get large enough. And some of these occur with higher frequency in infants. So that's definitely something to consider. But the category of choroid plexus tumors includes choroid plexus papillomas and more aggressive atypical papillomas and carcinomas. 70 to 80% of these choroid plexus tumors present within the first year of life. They arise from the epithelial cells that line the choroid plexus, and they usually occur in the ventricular system, although recently we saw our first case at our institution of an extraventricular choroid plexus tumor, which was very large and did present with macrocephaly, which was fairly interesting.
Wow.
But the most common, yeah, it was an unusual case. The most common location in children is the atrium of the lateral ventricle, followed by the fourth and then the third ventricle. And imaging shows a solid, avidly enhancing, usually intraventricular mass with papillary or frond-like morphology. And there's communicating hydrocephalus, which is thought to result from various combinations of overproduction of CSF, obstruction, and decreased CSF reabsorption. And there may also be CSF outflow obstruction due to mass effect, depending on where the tumor is. Importantly, because of the propensity for CSF dissemination, craniospinal MR is recommended at diagnosis and at follow-up, and recurrence is rare if the tumors can be completely resected.
So are there any syndromes that include macrocephaly as a feature?
Yeah, in fact, there are. So megalencephaly, defined as an oversized or overweight brain more than 2 standard deviations above normal, or hemimegalencephaly, can be seen in association with multiple different overgrowth syndromes, metabolic syndromes, lysosomal storage disorders, and neurocutaneous disorders. Also, mutations in genes within the PI3K, PTEN, AKT, mTOR pathway are associated with overgrowth syndromes and macrocephaly, which can lead to various genetic disorders such as PTEN, hamartoma syndrome, and tuberous sclerosis. So we won't go into depth here. Some more detail is seen in the article, but the PTEN hamartoma tumor syndrome refers to a group of autosomal dominant mutation syndromes with aberrant growth due to germline pathogenic variants in the PTEN tumor suppressor gene. And some examples include Cowden syndrome, benign Riley-Rubalcaba syndrome, autism spectrum with macrocephaly, and Lermite-Duclos syndrome. And in P10 hamartoma tumor syndrome, there's an increased risk of multiple different tumors, including breast, endometrial, and thyroid cancers. And the macrocephaly is usually striking, up to 4 standard deviations greater than normal, and is often the initially recognized clinical symptom that may prompt genetic testing. And in fact, this striking macrocephaly is one of the key features of this syndrome. The most common MRI features can overlap with other disorders and include enlarged perivascular spaces and scattered static multifocal white matter abnormalities that don't change over time. Macrocephaly can also be a feature of some metabolic syndromes, and these and other genetic causes of macrocephaly are described in further detail in the article.
So finally, the last compartment discussed in the article is the calvarium. How can the calvarium be a cause of macrocephaly?
Yeah, so this one, pardon my pun, but you have to think outside the box a little bit when you think about this one, because there are a couple of different reasons. So
Pun intended?
Yeah, pun intended. Pun was very much intended. In achondroplasia and syndromic craniosynostosis, macrocephaly can be exacerbated by CSF outflow obstruction at the foramen magnum, which can lead to hydrocephalus. And then with with some open sutures, you can get expansion of the cranial vault. But other disorders such as beta thalassemia and skeletal dysplasias, for example, craniometaphyseal dysplasia, which we illustrate in the article, can lead to enlargement of the calvarial bone itself.
That's quite interesting. So yeah, remember, just don't think of what's inside, but think of the box. Actually, I guess that is the box. So thank you, Dr. Asha Sama, our neuroradiology podcast guest, for this episode of Radiographics podcast. I hope you enjoyed it. Please take a look at this great article and the beautiful images online. Thank you for your attention.